Okay, so hello everyone, myself Dr. Shomo Banerjee. Today we are here to discuss regarding the management approach of the rehydration therapy and the antibiotic treatment with you. Okay, so let's start with a basic assessment of the patient. So obviously you have to understand the patient with acute gastroenteritis. They usually present with nausea and the vomiting. So obviously as a result of that nausea, vomiting, and also there is a huge amount of the diarrhea. So this diarrhea is basically some isotonic fluid that has been excreted out through with the stool, and apart from that there is also some amount of the electrolyte loss, that is specifically the sodium, potassium, and in some cases the bicarbonate as well. So that is the number one thing, is that as a result of loss of the fluid from the blood body, that will eventually associated with the dehydration. So this dehydration is supposed to be needed to be classified, right? So that may be no dehydration, there may be some dehydration, and that may be severe dehydration in that case. Apart from that, there is a few clinical indicators that will also helps you to decide whether the patient doing good or not. It's a basically the bedside indicators like the capillary refilling time or the skin turgor, or in some cases mental status as well. Also you do need to understand there is a red flag signs and obviously the tachycardia. Uh, so if the patient comes to you with a more or less normal blood pressure with a tachycardia, so that means it's a pretty much in a compensatory stage. But if the patient started to develop the hypotension, so it's beyond the compensation. So in that case you do need to go for the rehydration therapy through the IV route. But obviously in case of the previous scenarios, you can try the patient with a ORS or the oral rehydration therapy in that case. So your principle of the rehydration therapy is to goal is to restore that intravascular volume. But not only that intravascular volume, let's suppose you are only try to restore that intravascular volume only. That will leads to do what? That will leads to there is a dilutional deficiency of the electrolyte. So you do need to correct the electrolyte as well. So now the thing is that whether you are supposed to go with the oral route or the IV route, that is basically your aspect to determine, like there is a specific indication for each to go with that, right? So we have WHO ORS composition in that case. Okay. Now regarding the investigation, so what are the things you are supposed to go for? Like suppose the patient is basically having some refractory diarrhea, not uh, uh, easily treated well, or they are not easily respond to the normal rehydration therapy. So there is a multiple amount or the multiple episodes of the stool is there. So in that case, like most of the cases of the traveler's diarrhea, they usually resolves on its own. So what you do need to do is that you just provide the patient with a rehydration therapy. But in some cases it is not possible. Like you are doing the rehydration therapy but the patient is not responding, so the patient is keep having the diarrhea. So in that case you do need to go for the stool microscopy, there is a stool culture. You might gonna need to go for the serum electrolytes and the urea creatinine. Okay, and there is a special tests are there like the clostridium difficile toxin or the PCR if needed. That will basically gives you an idea what is the possible underlying cause, so that you can start the patient on antibiotics in that case. Okay. Now regarding the oral rehydration therapy, what you do need to understand, so there is a WHO ORS, and nowadays we are using the reduced osmolarity ORS. Okay, so you can see that there is a new formulation of the WHO ORS has been there. So this WHO ORS basically contains the NaCl of 2.6 gram, the KCl 1.5 gram, trisodium citrate 2.9 gram, glucose around 13.5, water 1 liter, and the sodium, potassium like the 75 millimole, 20 millimole, and the chloride and the citrate 65 and 10 millimole, and the glucose is around 75 millimole concentration is there. Okay, is basically there. Now the water, like all the, one must ask the patient, or one must explain to the patient, like the formulation that has been available in the packet, that is supposed to be mixed with a 1 liter of water only. Otherwise the patient will develop some kind of uh, okay, 1 2 3 4 5, otherwise the patient will develop some kind of problem with that, because in that cases the osmolarity is basically goes what up, right? So in that case, if the patient consumes that high osmolarity uh, content in that case, so that will eventually leads to some alteration in the systemic side effect, right? So apart from that, let's try to understand the standard WHO ORS which is there previously, and there the concentrations are pretty much different from what we now use, right? So this is the one thing that is very much important. Now the indication, what you do need to understand, like obviously it is basically supposed to be taken on the par oral route. It's a indication is there with any kind of diarrhea, you should always start the patient on ORS solution in that case, in any kind of diarrhea, because as there is a loss of the water content as well as the electrolyte abnormalities are also there. One thing, that is the zinc supplementation is pretty much important while treating a patient with a diarrhea, and this zinc supplementation is especially very much important in case of pediatric age group population, right? In case of pediatric age group population. Now you do need to understand the IV rehydration therapy, right? IV rehydration, so your IV rehydration therapy is there. So this IV rehydration therapy is supposed to be started with a patient with a moderate to severe uh, a diarrhea in that case. So obviously we're not going to start the patient on the normal saline, because it basically doesn't replenish the bicarbonate and the potassium in that case adequately. So that's why our ideal fluid for in this scenario is the ringal lactate. Okay, so you do need to calculate the deficit and obviously try to maintain that ongoing loss as well. So on an average you can easily go with a 20 ml per kg per hour rate, and this amount of the fluid you can start transfusing for around 3 to 4 hours. After that you can go for reassessment whether the patient has improvement in the GCS, skin target, or the pulse rate and the uh, uh, blood pressure. But one thing that I would like to highlight is that the utilization of the urinary output. Okay, but for the case of the monitoring, suppose the patient is basically suffering from some kind of cardiovascular disease, but in that case your invasive monitoring of the blood pressure and the CVP monitoring, and you should adjust your fluid calculation according to that CVP monitoring in that case. Okay, now let's try to understand the other drugs that are basically available in our case scenarios. Okay, so among the anti-motility drugs, your loperamide is pretty much well known. Here, the dose you are supposed to start with the patient is basically 2 tablets of 4 milligram each, and that is supposed to be started on stat dose, followed by 2 milligram after each unformed stool, and that is not supposed to be extending 16 milligram per day for less than 2 days. So this is your loperamide. Apart from that, there is a opioids is there and the diphenhydramine is there. You can always give this drug in a patient with toxin induced diarrhea, but one thing you do need to understand, this is supposed to be given to the adult only. It is always, do try to avoid this patient in case of elderly population or in case of children. Okay, then comes your anti-secretory drugs, which is the resicadotril in that case, usually given in 100 milligram TID doses in that case, right? So as the name suggests, it's an anti-secretory drugs, right? So they are basically inhibit the enkephalinase, which is eventually uh, responsible for degradation of the enkephalin. So this is how they basically act and decreases or prevent the secretion of the electrolyte and the fluid in the stool. So that's how they basically work as an anti-secretory drug. So they are basically used in case of acute onset diarrhea in that case. Apart from that, we do have the antispasmodics, which is specifically to alleviate the pain in such cases. Okay. Now let's try to understand the general principle of the antibiotic therapy. So the most cases are basically viral, so there is a no antibiotics that is there. Apart from that, the indication of the antibiotic therapy, suppose the patient is basically having severe cases, there is a dysentery, there is a fever, or there is a cholera, or the patient is supposed to be like the immunocompromised state. In that case, you can easily go with that. Now the few empirical antibiotic choices that has been there. So for the cholera, we usually like to go for the doxycycline or azithromycin or in the combination in case of the severe patient. But that for the dysentery, it's a cefixime and the ciprofloxacin. Usually the traveler's diarrhea, not required any antibiotic therapy. It basically relieves on its own, but obviously it's a if the patient is basically not responding to the conservative management, you do need to go with a azithromycin. Then comes your Clostridium difficile, which is basically the metronidazole, and the vancomycin is there. So as we have already discussed, like the traveler's diarrhea, it usually relieves on its own, but the requirement of the antibiotics is very much rare in case of resistant cases only. Then comes the Clostridium difficile, which usually requires metronidazole and the vancomycin in that case. It's a pseudomembrane colitis in that case. So obviously you do give the patient with a oral vancomycin. Okay. Now the antibiotics to avoid, like avoid routine use of the fluoroquinolones because they are itself going to cause some kind of pseudomembrane colitis in that case. Like the broad spectrum agents are supposed to be also avoided, but also there is a risk of resistance and the side effect may be arises due to this. So always follow the local antibiotic protocol that has been there. Like suppose you are working in some hospital, obviously they usually follow some antibiotic protocol that has been released by the department of the microbiology of the every medical colleges or the every institute. So do follow that, like what are the empirical initial go-to antibiotics in your institute. Okay. Now the probiotic and the adjunct. So the role of the probiotic and the prebiotic. So your prebiotic basically disaccharides, and the probiotic basically some uh, bacterial or the microorganism that are basically thrives on the intestine, which are basically good for our health, right? So it's a normal gut flora. So in some cases, due to the diarrhea or due to some medication, in that case, they basically get away from our gut. So they are that is often associated with some absorption problem and all. So your disaccharides basically act as a substrate in that case. So that's why your probiotics and the prebiotics both are simultaneously given in some cases. Okay. Now, apart from that, as I have already mentioned, like the zinc and vitamin A supplementation is supposed to be made on a serious note, especially in case of children, right? Then comes your prevention. It's a safe drinking water, sanitation, and the hygiene is supposed to be maintained. Your rotavirus vaccination, especially for the children, is supposed to be given. And please do follow the proper food safety protocol in case of food poisoning and outbreak in cases. Thank you for today's session. If there is any query, do let me know. I'm happy to answer your queries in that case.